I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. We are live from the 2022 NEI Synapse, and I have here with me today Dr. Thomas Schwartz. We are talking about the neurobiology of sleep and how to treat sleep disorders. And I'm so excited to give you a chance to get some of your unanswered questions addressed today. Dr. Schwartz just completed his presentation with us on sleep, and let's dig into some of these excellent questions that we have here. My first question for you is, I have a patient who has brief, intense depressive episodes triggered by sleep deprivation and fully resolved by sleep restoration. What is happening in the brain to cause this switch to flip into a depressive state?
So I think that's a great question, and I'll try to keep the answer short. I think there's people, I even remember Dr. McIntyre talking a bit about this here at the Synapse. I do believe some mood disorders are circadian rhythm disorders, and certainly we'll see manic patients lose some sleep, flip into mania, but I do think there's a subset like the patient you describe and the question, who something goes on and their circadian clock is disrupted, they lose sleep, and it kind of creates a cascade into those classic SIGI CAP symptoms. So just like mania cascading or insomnia cascading into a full-blown mania, I have seen patients that cascade right into a full-blown depressive episode. And like you say, it kicks in over a few days. So one simple answer is some people's circadian systems are very sensitive to disruption. And whatever it is that disrupts them gets them in trouble and they get fully syndromal. And that's, a very clinical answer. From a biochemical answer, I don't know if there is a great, is it all norepinephrine, all dopamine, all serotonin either. But remember, at nighttime, your serotonin, norepinephrine, and dopamine are going up and down. And, what if they get into insomnia because that's disrupted? Then you develop depression, which we think is norepinephrine, dopamine, serotonin related for most people. So I'm going to bank on, disruption is disruption. So if it's not all a circadian insult, there's probably, some abnormality in one of the monoamines. And, treatment probably is a good sleeping pill. And the first hint of the person's not sleeping normally, get them on a sleeping medicine for a couple days. And I think you can avoid the depression spell. We've known this about bipolar for a long time. If we see the insomnia coming, we treat that, and then we don't have to add a lithium, a Depakote, or an atypical. So it's a unfortunate patient case, but I agree with you. We do see patients like that.
Excellent. The next question we have is, how do antidepressants affect sleep?
So many of the antidepressants that work through transporter reuptake inhibition, so the pump blocking drugs, SSRIs, SNRIs, NDRIs, SPARIs, tricyclics, what they do is when you raise monoamines, they don't let you get into deep sleep. So it is crummy, but many of our antidepressants destroy that ultradian sleep cycle architecture we discussed today. So, sometimes, people are less sad, less crying, less weepy, less anxious, less guilt-ridden, but then they don't get restorative sleep. We create micro awakenings and insomnia as a side effect, and we'll have to treat that with another medicine. The sedating antidepressants, trazodone, nifazodone, mirtazapine, do not do that. So they block serotonin 2A, which is almost the opposite, which gets your sleep back to more normal architecture. So if somebody's really suffering with insomnia as a key component, you may want to use a sedating antidepressant over a reuptake inhibitor. Or sometimes we use both. There's lots of data, for example, with mirtazapine adding to an SSRI or SNRI is a great combo treatment for depression, but you might actually even out their sleep too. So that's what usually happens, unfortunately.
Okay. May I know why Ambien is so demonized, even if it is a non-benzodiazepine, this person wrote?
Yeah, I'll take you a trip down history lane here. So Ambien, which is zolpidem, came to the market, not as a full benzodiazepine. In New York, we used to use triplicate, carbon paper prescriptions for the benzos, and then Ambien zolpidem came out and it was a regular prescription, albeit still controlled. And everybody switched to that drug. It was just easier to prescribe, easier to use. It works very well. 70-80% of our patients sleep better, no questions asked. So it is certainly a very effective sleeping pill. The negative is first in class. And then whenever you start to see problems, the media and everybody else gets on board. And then you would see cases of Ambien, made me take a weapon and start shooting. We've seen that with Prozac first in class. So I do think some of it's very artificial. But what we found out is zolpidem and the drugs in that BZRA family create some of these parasomnias where you wake up, you don't know you're awake. It's like an alcohol blackout. And people will sleep eat, sleep drive, sleepwalk, and certainly they could do some dangerous stuff. And that certainly made the press. Now, if I take you back through history, there was a true benzo called Halcyon triazolam that had the exact same problem. And we were always taught in the textbooks, it's a bad actor because of this. So the Ambien Lunesta Sonata drugs do the same thing because they're shorter half-life drugs. It's unfortunate. So they are very good, but you do need to warn patients that these things can happen. So I just think it was first in class, most advertised, most written about, and probably is unfair.
Yeah. This is an excellent question. What is more effective and safer in the geriatric population?
So I think you do want to avoid the benzodiazepines and the BZRA meds that we just talked about if you can. So anything that raises GABA A activity, it's psychomotor impairing, hurts your breathing, makes you more at risk for falls. So I do try to avoid the GABAergic drugs. The drugs with some data, I think, are the melatonergic ones like Ramelteon, Rosarum, for example, and Doxepin, which is Silenor when it's used on label for insomnia. So I do think those are the two I prefer in geriatric patients with insomnia. Again, we always try to start and use the lowest doses. So maybe you use those, and then if those, really don't work for you, you do have to move on to the DORAs or the BZRAs, which again can have addictive properties, etc. But I would probably go to the DORAs next, and then I save the BZRAs and the benzos for last.
The next question I have for you, this person wrote, often I have patients who fail to respond to numerous sleep med trials and CPTI. Referral to pulmonology is not helpful. Any additional suggestions for treatment-resistant insomnia?
Yeah, it's a great question. I'd actually call that treatment refractory. And I've had those cases where, you try the major classes of the sleeping meds, monotherapy approaches, and you march through the 4 or 5 different families. CBT fails, then you send them to a sleep medicine specialist to make sure it's not an apnea or something like that. I think at that point, you've done a good job. You've kind of tried everything or almost everything that's out there. So here's what I would do. You look at your trials, and have you tried, if you remember the chart from the lecture with all the medicines on there, have you tried a true benzo, a true BZRA, a DORA? Have you tried an antihistamine? Have you tried a calcium channel blocking epilepsy medicine like pregabalin or gabapentin? Have you tried dampening norepinephrine with clonidine or prazosin? And, at this rate, if you haven't tried an atypical antipsychotic, which probably at least middle dosing now, there you are getting some dopamine blockade. If you've truly marched through a monotherapy in each of those, I think you've tried almost everything that's out there. And then you can combine them. So you never combine, just like in depression, we don't combine 2 SSRIs. They're the same mechanism. But for refractory insomnia, maybe you add a melatonin drug and an antihistamine together, 2 different mechanisms. If that fails, melatonin drug, antihistamine drug, and maybe a blood pressure norepinephrine dampener. Again, multiple side effects, multiple copays. You have to weigh the risks and benefits of a polypharmacy approach, but you could try a couple of those and decide risk versus benefit. And then outside of that, it's tough. I don't know what's left. You keep trying multiple combinations, bigger doses. Some places have a very good sleep lab where they will actually do a very good job measuring your circadian clock, and then they can get into really fancy light-based treatment. But not every city has one of those centers, so that might be a high-end referral. So it's tough, and like everything else, you're gonna see patients you just can't help. Sometimes we do flooding, which is we make patients do an all-nighter. And that actually increases adenosine and sleep drive, and they kind of face their fears because sometimes it's just the psychological component driving up fear. Even though CBT is supposed to help that, maybe it didn't. And sometimes it's once a week you're going to pull an all-nighter. And maybe that's a treatment option too. But it's tough. You'll meet some refractory cases. It's true.
This next question says, are you familiar with the studies that discuss hydroxyzine is not as anticholinergic as we previously thought, and therefore may be a safe option for insomnia in the older adult population?
Yeah, again, I think it's a tough call. So I don't necessarily know which study the question is referring to. Yeah, I do think there's a debate about how anticholinergic is it, but it is. So whether it's mild, moderate, or severe, it's probably something we don't want to use a ton of. So even, mildly anticholinergic drugs like olanzapine, the antipsychotic, for example, it's mild compared to some of the older low potency antipsychotics, but it's still there. So I think I do try to avoid hydroxyzine. If I do use it, I'll use the lower 10 milligram dose. And, I think they're just cleaner antihistamines, doxepin, maybe trazodone to some degree off label that you can use before you get to hydroxyzine. But hydroxyzine is a good drug. But I've gotten in trouble more with it than it's helped me just personally with my geriatric patients.
Okay. Are there fewer hangover effects with the use of orexin antagonist medications in comparison to trazodone or other medications used for sleep?
So I think so, just from a practice point of view. So again, I use a lot of trazodone. I use a lot of doxepin, and you can get antihistamine hangovers. You can get it from diphenhydramine over the counter too. And some people are really sensitive to it. The benzos and the BCRAs, same story. You can get a hangover effect the next day. I think I do see less of it with the DORAs. They're not, GABA A. They're not antihistamine. They work a little differently, as we talked about. They're orexin blocking. They feel a little different in practice, but can you get that patient that still wakes up groggy? Absolutely. So it is possible, but to answer your question, I think I see less in practice.
This next question says, please comment on treatment strategies for patients who use cannabis every night for sleep.
Yeah, that's another one, and I could go on for about an hour, and I really don't want a soapbox whether weed, pot, cannabis is a good or a bad drug. In the grand scheme of things, I don't think it's a horrible agent, except in every one of my patients. So it destabilizes bipolar, it creates more psychosis and schizophrenia. I think it's actually very poor at treating anxiety. So unfortunately, I do see a lot of patients. My state has now legalized it. So, I think it's hurting most of my patients. And I run into this. They're on it. They think it's helping. I think the discussion you have is, I don't think the cannabis is a bad drug, but for you wouldn't be here asking me for a sleeping pill if it was working great. So use a motivational interviewing approach, in a nice way. How's it working for you? And let's get honest about it. And then I'm still only sleep 2 hours a night. Well, would you entertain me swapping it out? Maybe you smoke cannabis, harm reduction. Maybe you can just smoke cannabis, in the day, but quit it before lunchtime. And then let me use some prescription things in the evening at bedtime and just see if we can actually find you a better drug. And so sometimes, you're not really getting in people's faces saying quit it all, or just smoking on the weekends, have a good time with your friends, but Sunday through Thursday, let's use my products. So I do think, that's the approach. From a drug point of view, what I found the most effective, though it's hard, are the sedating antidepressants. So trazodone, nifazodone, mirtazapine. So they're a little sedating, they're a little mellowing, they're a little groggy feeling. Nothing that is kind of like the same as smoking, pot before you go to bed, but it's close. And on that level, you're never going to get the same feeling, but it's close enough. And so I think that's what I would typically do. I'd stay away from the other controlled substances, benzos, BZRAs, DORAs. Now somebody's doing 2 controlled substances at night. So I do like the sedating antidepressants in that patient group, predominantly for insomnia.
Okay. This next question is, do some sleep meds work better than others in patients with untreated sleep apnea who do not tolerate CPAP therapy?
Yeah, and that's a slippery slope with people with apnea, particularly bad sleep apnea. I do not use any of the GABAergic drugs, benzos or BZRAs. They're clearly, respiratory suppression. And then everything else I think is fair game. The antihistamines, the melatonergic drugs, even the DORAs, I think they're a bit safer. One is I always advise people, though, before any sleeping pill, can we try a different mask, different apnea approach, different machine? They do make a mouth guard, which pushes your bottom jaw forward. So if you can't tolerate a mask, can you at least try the mouth guard? I really would like that better before we go to a sleeping pill. But if you do need to use a sleeping pill, again, you start low and go slow, but try to avoid anything that manipulates GABA would be my advice.
Okay. And that takes us to our last question, which is, many of my patients with autism report excessive daytime fatigue. Do you know of a reason and best treatment for this?
So that's another great question. I don't know if I know the reason. Make sure there's not a depression or an anxiety disorder. Certainly make sure they're getting enough sleep at night. If they already have insomnia or day-night reversal, they have, different, schedules that keep them up at night, these kind of automatic rigid behaviors. So we'll just make sure it's not actually part of the autism. But I think they can have idiopathic hypersomnia like everybody else. And then the treatments we talked about today, can you raise norepinephrine, dopamine, all the same rules I think would apply for those patients.
Excellent. Well, thank you so much for joining us today, Dr. Schwartz. And thank you, everyone, for tuning in to our podcast. Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.